When we say pain, people usually complain low back pain, neck pain, knee osteoarthritis pain, shoulder pain, dental pain, tension type headache or migraine or menstrual pain. In many of these scenarios, non-steroidal anti-inflammatory drugs are very effective, almost in 80% of cases. They reduce inflammation, tissue irritation. They decrease prostaglandin, and prostaglandins are the molecules which cause pain and which anticipates pain receptors action. But they are not totally safe. They have some risks, especially in gastrointestinal bleeding risks or kidney risk, sometimes cardiovascular risk. That's why we have many non-steroidals. They have different strength, different safety, and we will discuss top 8 most effective and safest ones. Meloxicam is the first. It's not strongest, but it's one of the safest choice. It is best for osteoarthritis, knee pain, chronic hip pain, and inflammatory arthritis scenarios. It preferentially blocks cyclooxygenase 2. It means that it is selective and it irritates the stomach less compared to other non-steroidal. In real practice, it is used for chronic conditions to intake for months and sometimes for years. Sometimes it requires gastric protection additionally, especially in older population, and gastric protection is with proton pump inhibitors like omeprazole or lansoprazole or pantoprazole. The second medication is celecoxib. Celecoxib is a very selective cyclooxygenase 2 inhibitor. It is typically prescribed for osteoarthritis, rheumatoid arthritis, chronic inflammatory back pain. Gastrointestinal risk is minimal at this case because it largely spares cyclooxygenase 1 and it does not cause irritation of gastric mucosa, and it has very little risk of gastric bleeding compared to other non-steroidal medications. That's why it is used in people who have more risk of bleeding, and when we want safer alternatives of non-steroidals, then celecoxib is considered one of the best. But it's not for acute pain, it's not for dental pain or post-operative pain or when person has acute headache. It's for chronic pains and chronic inflammations like joint pains. The third is ibuprofen. It is most balanced for everyday use. That's why in most guidelines, ibuprofen is the first. So if you have headache, ibuprofen is the first. If you have acute pain, dental pain, usually ibuprofen is the first person can use. It is considered safe. It has perfect safety profile for short-term use, not for long-term, not for months and not for years, but short-term. But it inhibits both cyclooxygenase 1 and cyclooxygenase 2. That's the main problem because it is non-selective and it can irritate gastric, it can cause bleeding of gastric, but this risk is small when you use it only for one day or several days. That's why ibuprofen is considered first-line treatment in most guidelines. Typical dosage is 200 to 400 milligrams every 6 to 8 hours, or 400 to 600 milligrams in more significant pain or inflammation, and daily 1,200 milligrams per day. And higher only add some risks and no important benefits. Proton pump inhibitors are usually reserved for high-risk patients. For example, if person takes ibuprofen for headache, it does not require any additional protection like proton pump inhibitor like omeprazole or pantoprazole. Fourth important medication is naproxen. Naproxen is used for steady control because it works same mechanism, but it has prolonged half-life. It means that it has more stable prostaglandin suppression across the day. That's why it has prolonged action. Naproxen is effective for osteoarthritis, for back pain, for tendon-related pain, for menstrual pain, and its effectiveness is around 70 to 80%. So it's very effective, but it's not selective. Typical dosage is 200 to 500 milligrams per day or twice a day. It depends. Sometimes 1000 milligrams per day. Naproxen is preferred when we want prolonged action medication and non-steroidal, and also when there is cardiovascular risk, so risks. And next is Diclofenac. Diclofenac is even stronger than above mentioned. It is fast and it has good penetration into inflamed tissue, often experienced as stronger than ibuprofen and naproxen for acute pain. It is commonly used in orthopedics or in dentistry or post-injury pain, but in guidelines it is used only for short terms because it has less favorable safety because of cardiovascular risks, especially in high doses, especially when taken prolonged. It inhibits both cyclooxygenase 1 and cyclooxygenase 2 and blocks prostaglandins, and it has strong analgesia, so strong pain relief, but not very safe. Typical dosage is 50 milligrams 2 or 3 times per day, and maximal dosage is around 150 milligrams, not more. And duration should be limited only for several days. And with diclofenac, proton pump inhibitor co-therapy is also important and appropriate in most cases, unless the patient has clearly low risk and course is truly brief. Another important medication is ketoprofen. Ketoprofen is also non-selective and it is fast and potent. It's also important for back pain flares or sprains and strains and sometimes dental pains. So it's very effective, but it's not for everyday use because risks of gastrointestinal and kidney risks. It inhibits both cyclooxygenase 1 and cyclooxygenase 2, and adult dosage is around 50 milligrams per day, 2 to 3 times per day, and upper limit is 200 milligrams per day. Beyond this, or person with high risk, proton pump inhibitor protection is considered important, like omeprazole or lansoprazole or pantoprazole. Next important non-steroidal is etirocoxib. It is a strong selective cyclooxygenase 2 inhibitor with once daily convenience and good gastric safety. It is one of the safest medication, especially for everyday use in chronic inflammation like osteoarthritis, ankylosing spondylitis, which is an inflammatory back arthritis, and acute gout. And some patients can feel more comfort even compared to diclofenac level. So it is strong for inflammatory pain. Its central limitation is cardiovascular risks and blood pressure elevation, especially in higher doses, and it should be avoided in people who already have ischemic heart disease or prior stroke or uncontrolled hypertension. Typical dosage is 60 milligrams per day. Higher dosage also possible sometimes, and proton pump inhibitor co-therapy is not routinely required. And last and strongest is ketorolac. Ketorolac is a high-intensity rescue analgesic. It is non-opioid category, but it's very strong for moderate to severe acute pain. and it has very strong analgesia when needed for short, for example, post-operative pain or renal colic, severe dental pain or acute trauma pain. It's not designed for chronic inflammation control and chronic use because it has high toxicity risk, especially for gastrointestinal bleeding, for acute kidney injury, and the risk rises sharply when duration is longer and person's vulnerability is high. Generally, proton pump inhibitor protection is required. It's important and it's standard when we use ketorolac. And even with the protection, the key safety rule remains strict dosage and duration discipline, because even with proton pump inhibitor, ketorolac is not completely safe.